Thank you, Matthieu. Do you want to stay up, Matthieu? I'll ask the speakers to join me on the podium. We have about 10 minutes for questions. And please either join me at the desk here or in the more comfortable living room chairs. Perfect. Yeah. So maybe since Matthieu's here, I'll ask my first question to you. And of course, the audience also, please put your hand up or indicate for the mic if you have a question. But so on the question of follow-up in vasculitis, is there a timing that you think that should be done routinely? What should be our guidance to the clinicians about that? Here.
Thank you, Rob, for the question. That's a very good question. I don't think there's a clear answer to that. As I mentioned, you can normalize a scan very quickly. So after only a few days of steroids, you can see that the study normalizes. And in a subset of patients, you see that the uptake will last essentially forever. And we don't yet know what that means. And we don't know if it will predict relapse or not. So it's not like in cardiac sarcoidosis where you can really tailor therapy based on if they respond or not to on the imaging. And I don't think there's enough evidence to really answer that question. So what we do with our clinicians is we don't do routine follow-ups, but we tell them if you suspect that there's a flare-up and you want to confirm it, then we will do the imaging.
All right, Dr. Someone, you talked about AI and sourceless DSPECT. I thought that was very exciting, interesting application for AI. What's the evidence that's going to give us advantage in terms of accuracy? And if we're still building that evidence, what else do we need to be able to show that?
So the proof of concept of this, I think, has mostly been accrued from observational studies. And in comparison to CT attenuation correction, including the TrueCore data, which is, I think, the only prospective sort of evaluation in the clinical realm. Most of the others have been retrospective observational data. I think we really need a prospective study and with some sort of, standard comparator like, coronary angiography. The big question is, does it overcorrect? I think, and that is the question with all sorts of attenuation correction algorithms. And that's particularly difficult to ascertain, one, because we've only, most labs have small numbers of positive studies. And unless you have angiography in everybody, that's very difficult to ascertain. But that would be the single most important bit of information, I think, going forward.
Thanks very much. Dr. Schwartz, how often are you using flow quantification with SPECT? And what cutoff are you using for low risk?
It's a great question. In 2.5 years, we started in February 2021. We've done over 600 cases now. Our heart failure transplant group, we have a large transplant, very successful program in Rochester. They routinely get it for follow-ups annually, whereas they used to get dobutamine stress echoes or MPIs. We have a few clinicians who are quite active, some of our more busy expert clinicians, who really understand the value of MBF, and they order it selectively and frequently. So we do about 0 to 5 a day. It does take more time than PET. It does take more time to acquire, more time to process. The reproducibility technically is excellent. We don't have day-to-day studies for variability, but it's become a routine part of our practice. And I think our staff feel that this is really an exceptional opportunity to offer optimal care for our patients. And we're routinely finding, this really surprised me, I must say, as an experienced nuclear cardiologist for decades, trained at Yale, been at Rochester since '85, I was really surprised at how much significant, hemodynamically significant disease we were missing with routine MPI. So I regard it in selected patients as a very important opportunity to expand what we're doing.
And I would add to that how frequently non-responsiveness to dipridamol exists too. We have a question in the audience.
Dr. Jüngling from Edmonton, Alberta. I've got a question for Dr. Schindler. Thomas, I've been witnessing you chasing microvascular disease using PET perfusion for more than 2 decades now. Still, the incidence of CMD is reported to be as low as 0.2%. Have you been chasing medical zebras with an extremely expensive cannon for all the time, or is the incidence just reported too low because nobody uses PET perfusion?
Good point. You may want to repeat this question in interventional cardiology, and then I mean, when patients go to the cath lab and they have non-obstructive coronary disease, and then they like, of course, to assess microvascular dysfunction with acetylcholine testing and flow measurements. But it's very busy in the cath lab. You lose much time and revenue because the cath lab is blocked for 1 hour. Acetylcholine testing may cause also sometimes spasm and dissection with the catheter. And then we translated that to PET. We started with PET in Freiburg at that time, and I was in the cath lab, translated to the PET imaging. I think in patients with non-obstructive coronary disease, we see it in 20 to 30%, especially in St. Louis in patients with morbid obesity, the endogenous form, we see it in about 40%. So it depends what population you examine. And of course, when you go to young patients or normal weight, then maybe the prevalence goes down to 5%. Then they have more the classical microvascular dysfunction or more vasospasm, especially young women, premenopausal. And so I think it's now that we have PET and also now SPECT is coming, we detect more microvascular disease that we have missed in the past. So I think that may explain and reconcile the findings between invasive and non-invasive imaging. Good point.
If I can just add to that, I agree with the comments. I do think we're seeing it less often than we thought we would see it. But it's also a complex picture because there's non-obstructive disease, or no obstructive disease, I should say, or there could be diffuse atherosclerosis, which is a different entity than true microvascular dysfunction. And I think there's a lot of confusion about that in the world, and I think we have to try to educate people about the fact that those two things are different. Combined with partial responses, all of these other things kind of mix in. So my last question is for Dr. Akincioglu on PYP. Can we now safely say that PYP can replace biopsy? And what's the role in follow-up of patients with amyloid?
So I guess as long as the light chain disease is ruled out, PYP is quite reliable in diagnosing and in non-biopsy diagnosis of TTR cardiac amyloidosis. But 4 criteria still exists. You have to have the heart failure, suspicious echo or MR, and PYP uptake and exclusion of light chain. So I think as long as all those criteria are met, PYP scan is quite reliable in avoiding biopsy. For follow-up, I fear I can't really tell yet. There are a few cases here and there I hear, including our center, that we have done follow-up scans on patients who are on treatment. We have seen changes in PYP uptake. But again, still exact mechanism of PYP uptake is unknown. The theory exists that these fibrils are high in calcium and that's where PYP goes. And with the silencers and the stabilizers, we have seen decrease in uptake. But it just tells you that the patient is responding to treatment as long as it correlates with the clinical symptoms. So for the outcomes, I think it will be a longitudinal process to really figure out if there is a true role and what that means in follow-up scans. For asymptomatic gene carriers, I wanted to emphasize that actually once you start screening them, and if you have a negative scan, when do you rescan? Do you have to wait until the symptoms develop, or is there a clinical period, 1 year, 2 years? We don't know yet. We have one case that we screened, we scanned first time. It was coming from a neurologist because the patient had familial ALA60 mutation, and she was negative in every way. And the next year, she has another screening, and she was referred to a cardiologist. Cardiologist, unaware of the previous scan, asked again, and this time it was focally positive. The patient was still somewhat asymptomatic. The third time, she developed mild orthostatic symptoms. Still there, it doesn't, like, she didn't have neuropathy or anything. And this time, the cardiologist, I guess, were in the academic center. Out of academic interest, he asked again. 3 years in a row, she was significantly positive. So it happened all within 3 years. But would it happen in a yearly basis in every gene mutation, in every gene carrier? I highly doubt it. Some mutations, I guess, the progress rate is different. So I can't really answer that yet. Maybe in 5 years' time, hopefully.
One short question. Yeah.
For Dr. Schwartz, regarding the what's your opinion for dual SPECT if we can assess gated SPECT myocardial function for BYP, for example, and rubidium, or for example, maybe perfusion, if there is contradiction between the function for both or not, or discrepancy, I mean.
Discrepancy between in dual.
Discrepancy in function if, by gated SPECT between BYP, gated SPECT if so, and myocardial perfusion gated SPECT.
Discrepancy in function measurements between perfusion and BYP.
Yeah. So
Thank you.
when you say discrepancy, when we see the HMDP or PYP localized in the LV cavity, which we can clearly identify because of the perfusion tracer, we know it's negative.
No, can we rely on PYP gated SPECT by for function measurement or not?
Yeah, you can also gate it. I didn't show a case of that, but we have them. You can actually gate when you when you have a positive case and you gate it.
I mean,
it looks like perfusion. Yeah.
Has been done before, or
asynchronous technique, you actually are looking at the combination of both the MIBI perfusion tracer and the HMDP or PYP together. Yeah, and it looks like a gated SPECT MIBI.
Yeah, it's not, you mean the BYP was if it is positive, grade 3, for example, was not conclusive for that, for assessment of left ventricular function or not?
We have not routinely used that to quantify ventricular function, but looking at the gating pattern makes it very obvious what's going on diagnostically in terms of the presence or absence of disease.
Thank you.
So I guess when there's diffuse infiltration in the myocardium, and you can gate the pyrophosphate as the images are clear, but I think the function, the details of this function is better with echo, that you can do strain analysis and you can see the segmental and LVEF may not change for a while. These patients, even with significant amyloid, they may have preserved EF. They have heart failure with preserved EF. So we don't just rely on EF, but even segmental. I guess the echo would be.
Dr. Ruddy and I were just talking about this yesterday in the car. Brett Sperry has actually shown when he was in Cleveland that the regional preservation of myocardium without infiltration, but with more PYP baseless. So when you have an apex to basal ratio, he reported that actually was a favorable prognostic sign. And Dr. Ruddy's now doing some more detailed analyses of segmental perfusion, amyloid infiltration. Yeah.
All right, thank you. It was an outstanding session.